Greetings. Welcome back to PBH 275, Injury Prevention and Control. This week's topic is a diverse array of injuries and other negative outcomes that we collectively refer to as iatrogenic injuries. To answer the first question that many of you probably have, what are iatrogenic injuries? We have to start by defining the word iatrogenesis. And this comes from two Greek root words, iatros, meaning healer, and genic, meaning origin. So in other words, healer origin would be the approximate translation of the word iatrogenesis. In our current language, when we talk about iatrogenesis, what we're talking about are the risks, the side effects, and the unintended consequences associated with physical health, mental health, pharmaceutical, even public health interventions. And so next we're going to talk about what iatrogenic injuries mean. For at least a couple of decades now, injury prevention professionals have started to think of the types of harms that come from treatments as a separate category of injuries and started introducing the concept of iatrogenic injuries. Back in 2005, Gilbert Lau defined iatrogenic injuries in the following way. These are injuries that are induced by or resulting from interactions with the health professions. Now, when we talk about iatrogenic physical injuries, and we'll talk about mental and social injuries later on as well, generally, iatrogenic physical injuries do not stem from the primary reason for the initial interaction with the healthcare system. This is another injury, sort of separate from the initial primary reason why a person interacted with the system, that results from the treatments that they receive. When we talk about iatrogenic injuries, there's a wide variety of causative agents and actions. Some of the major ones we're going to talk about in this lecture are the following: medical errors, adverse reactions to drugs or treatments, healthcare-associated infections, and the mental and emotional trauma resulting from treatments, particularly very invasive treatments such as chemotherapeutic treatments, radiation treatments, treatments that involve amputation. There's a lot of mental and emotional trauma that results from that, and that can actually result in iatrogenic injury. When you hear the term iatrogenic injuries, much of the time, I would probably say most of the time, what's being talked about are physical injuries suffered from medical or pharmaceutical treatments. But of course, I want to make it very clear that iatrogenesis and iatrogenic injuries are not limited only to physical injuries from medical and pharmaceutical treatments. As I alluded to in the previous slide when talking about some of the more invasive treatments people sometimes have to go through, those can cause mental health injuries as well, particularly if the treatment involves the loss of function of a body part, or the inability to do some things that the person was able to do before they had to do the treatment, which maybe the treatment saved their life and prolonged their life, and that's a good thing, but now going forward their life is going to be fundamentally different, and that can be mentally and emotionally traumatic. And those are considered iatrogenic injuries as well. As public health minded people, I want you to be acutely aware of the fact that even though nobody goes into the field of public health intending to cause harms to individuals or to populations, a lot of public health interventions throughout history have had unintended negative consequences, which some of them should have been anticipated and considered before the public health intervention took place. Some of them could not really have been foreseen, but there have been physical, mental, and social harms resulting from public health interventions, and that's something we're going to talk about later on, and something that, again, we just have to be mindful of and make sure that whatever public health we do, that we're controlling for unintended consequences to the degree that we can, that we're considering them, and that we're continuously monitoring to make sure that what we're doing is not creating another type of harm that would not exist if our intervention was not occurring. So this is why it took me several slides to fully explain what iatrogenic injuries are, because they're not just one thing. And this means that they're kind of hard to quantify as a whole, but we can quantify or estimate the component elements that contribute to iatrogenic injuries and try our best to see if we can apply some control measures to those. We're going to talk about some of these components of what we call iatrogenesis or iatrogenic injuries in terms of their prevalence. As far as we know, some of them have not been directly measured and have to be indirectly measured, their impact, which we certainly can know, and again, possible control measures. We're going to start with one of the most sort of clear and obvious examples of iatrogenic injuries, which is medical errors. Medical errors are basically any incorrect action by a physician, nurse, surgeon, pharmacist, or other healthcare personnel that directly lead to an injury. Some examples that used to be more common, or that are thankfully becoming less common, are things like inadvertently leaving a surgical tool inside a patient after they've been sewn up, or performing a glaucoma surgery on the incorrect eye. So those are the most obvious examples of medical errors. There's another type of medical error where it gets a little bit fuzzier, and that's when patients have an adverse reaction to a drug or treatment. We'll talk about adverse reactions to drugs as a separate issue later on, because a lot of times the patient's vulnerability to the adverse outcome was not necessarily known before they went in for the treatment. Now, the one category of these that we unequivocally consider to be medical errors would be if the patient's vulnerability to the adverse outcome of the drug or treatment was known beforehand and it still occurred, or if it should have been known. If a simple and reasonable genetic test, for example, would have determined that this particular drug at this dose was going to have a very bad outcome for this patient, then that's often called a medical error, as well as an adverse reaction. If we now want to address the question of how big of a problem are medical errors in the United States, it's not an easy question to answer, and in a little bit I will talk about why tracking of medical errors is more difficult than you probably would imagine that it should be. It's hard to estimate the prevalence of medical errors due to the variability of failures, outcomes, and terminology. Plus, we don't have a uniform reporting system. As I just talked about in the last slide, sometimes an adverse reaction to a drug or treatment is actually a medical error, sometimes it is not. And again, not having a uniform reporting system for these types of things, it's hard to pin down an exact number. What's not a perfect proxy for medical errors, but certainly something that gives us an idea of the impact that medical errors have, is the insurance industry. What premiums need to be paid for malpractice insurance is certainly a imperfect, but still somewhat of a proxy for whether medical error costs are going up or down. And the truth is, for the last decade, the U.S. cost of medical malpractice liability insurance has continued to grow every year, and faster than the rate of inflation, so it's growing more than just normal inflation. A 2013 study published in the Journal of Patient Safety, which estimated the patient harms associated with hospital care in the United States, found that their estimate was that there were premature deaths of about 400,000 people per year due to what they deemed to be preventable harm to patients. Now, obviously, they didn't count every single one of these. They just did some surveys, had some other interesting methodology, and then from that kind of projected it outward. And as we'll talk about later, it's hard to track medical errors, but this was one of the first reasonably good published estimates we saw. Basically about 400,000 people per year die prematurely because of something that happens in a hospital that was preventable. In 2024, Newman Toker and colleagues did another estimate. This one was published in the BMJ Quality and Safety Journal. They estimated that 795,000 people in the U.S. were either suffered death or permanent disabling injuries as a result of misdiagnosis-related errors. So that means that something was not diagnosed correctly, and that led to either death or a permanent disabling injury. Again, there were many assumptions that went into this estimate, but still the methodology is interesting at least. And so yeah, this is a very large magnitude of a problem here in the United States, and honestly, everywhere else in the world as well. Another way that we can attempt to quantify the prevalence of medical errors is to actually survey people about their experiences and interactions with the healthcare system and ask them directly if they've experienced medical errors, improper treatment, anything like that. And so in 2017, a fairly large survey was conducted by the University of Chicago and the Lucien Leap Institute. And they surveyed more than 2,500 adults in the United States. And what they found in this snapshot was that 21% of the respondents reported having personally experienced a medical error, meaning they themselves had been to a hospital or some other healthcare facility and experienced a medical error. Many of these had happened within just the past 12 months. 4% of the 2,500 plus respondents reported a medical error in the past year, 6% within the past 5 years, and the remaining 11% of those who reported experiencing a medical error, the medical error had happened more than 5 years ago. In 2018, a survey was done of 1,010 adults in Iowa, and this was by Lind and colleagues, and you see the link down at the bottom of this page. 18.8% of these respondents to this survey in Iowa reported a medical error in their own care or in the care of someone close to them, such as a family member. What is interesting is, of these people who experienced a medical error in their own care, not even quite 40% of these people were notified of the error by the responsible provider. A lot of times people had to realize the medical error from doing their own research, from going back later on for complications and for things like that. A lot of times healthcare administrators and facilities are reluctant to admit that a medical error occurred for reasons that we'll get into in the next slide. Let's now talk briefly about why medical errors are kind of difficult to track and why it's hard to ever get an actual, real, concrete number for how many medical errors are occurring in whatever jurisdiction you're talking about. We're talking about the United States mostly in this lecture, but part of the reason is that the word error, it creates a stigma, first of all, that somebody did something wrong. It creates litigation fear in whoever is believed to be responsible for the error, or the organization employing the person who is believed to be responsible for the error. And it leads to argument over the definition. As we talked about earlier, sometimes it's not that a medical error occurred so much as just there was a difference of opinion about which course of action should have been taken, and maybe the outcomes of the one action proved to be not so good, or in the case that people have unique susceptibilities that were maybe not reasonably foreseeable before they went in for medical treatment, drug treatment, anything like that. But this all leads to underreporting. And then when you get under the hood beyond this, you see some other issues in epidemiology that make it hard to quantify medical errors. One of these is informational asymmetry. On almost every situation, the healthcare provider is going to know more about the condition and the things that can happen than the patient will. This means that a lot of times patients will not necessarily know that a medical error occurred. They'll just assume that that was a natural side effect or reaction to something, whereas the people on the other side know that that shouldn't have happened, that must have been an error, and then that gets into what are you going to report. So that's a form of informational asymmetry. There's also survivor bias often plays into account here, where, of course, if a person dies as a result of a medical error, then they're not going to be around anymore to report what happened to them. And the survivors of a family member who dies after interacting with the healthcare system, they might not know the complete facts. They just know that this person they care about is no longer with them, and therefore they might sort of assume that a medical error occurred when it might or might not have happened. So survivor bias can kind of go both ways, and so can hindsight bias. I hinted at this a little earlier when a lot of times there's two or sometimes even more tracks that a treatment or a medical intervention or a mental health intervention or any other types of intervention can take, and where a patient and a provider has to make a choice about which direction to go. And a lot of times in hindsight, if one particular track that is chosen doesn't go particularly well, sometimes people can say that, oh, that must have been a medical error, should have made a different choice. In hindsight, yeah, maybe so, but at the time, with the information that everyone had, that might not have necessarily been anything that would qualify as a medical error. So these all skew attempts to quantify medical errors. Now, if you're wondering what kind of tracking systems exist at the federal level, not very much, honestly. The Food and Drug Administration does maintain an adverse event reporting system, but this is only for drug and therapeutic biological products. And whether adverse events from these things get reported or not is based on voluntary information provided from healthcare professionals and also from manufacturers of drug and therapeutic biological products. The Centers for Disease Control and Prevention does have an ICD-10 code. They've actually got two ICD-10 codes in WSCARs for adverse effects, one for medical care adverse effects and one for drug adverse effects. But the truth is, those codes are not used very often. Certainly, they do not appear to be used very often to classify particularly causes of death that are due to medical care adverse effects or drug adverse effects. Most likely, the problem is severely undercounted because a lot of times a different ICD-10 code will instead be applied to a death or a serious injury where the medical care or drug adverse effect was sort of a underlying cause, but the actual cause of death or serious injury was something slightly different. So, as we'll show you next, the CDC data is severely undercounted. If you go into the CDC WSCAR system and use medical care adverse effects as a cause of death and look at 6 years of data from 2018 to 2023, you'll see that there's been a range between a high of 5,414 of these deaths reported in 2021 and a low of 2,633 medical care adverse effect deaths reported in the year 2023. And based on every other type of measurement that we even try to do using reasonable epidemiologic tools, you can see these are severe undercounts. There's no way that only 25,000 people have died in the United States in a 6-year period as a result of medical care adverse effects. But again, the WSCAR system only counts deaths or serious events for which that particular ICD-10 code is used as a cause of death or cause of injury. And so this is the data we have. On the next slide, we will move on to the next category of iatrogenic injuries, which is adverse effects due to drugs and treatments. But since we were already talking about the CDC WSCAR's data, I will go ahead and show you now the data from drug adverse effects deaths in the years 2018 to 2023. What's interesting to notice here is that in the years 2020 and 2021, there was a bit of a spike where the number of deaths from drug adverse effects went up to 560 in 2020 and then 637 in 2021 before falling back to into the 300s in 2022 and 2023. During the early and middle stages of the COVID-19 pandemic, a lot of people were trying a lot of different drugs and other medications in hopes that they would provide a little extra boost to the immune system. And unfortunately, some of the things that were used by people did result in some fatalities. But as you can see, there have only been a total of 2,900 that were coded by ICD-10 code and entered into WSCARs as drug adverse effect deaths in the 6-year period from 2018 to 2023. Now we will talk about adverse reactions to drugs or treatments, which is a very common form of iatrogenic injury. This is basically any situation where drugs or treatments are the proximal cause of an injury, where without the drug or the treatment, the injury would not have occurred. Now, adverse reactions to drugs or treatments, again, they can be a form of medical error if the adverse reaction stems from provider negligence, where the provider knew about the potential for the adverse reaction and didn't do the right things, or they didn't pursue a good enough medical history and should have known with a reasonable check of medical history that this could have happened. So in that case, it could also be coded as a medical error. The problem a lot of times is that there's a very narrow therapeutic window in a lot of drugs and a lot of treatments. And oftentimes the therapeutic and toxic doses overlap, and the windows between them are very narrow. An example I'll show you on the next screen are the plasma level of a drug that can make the drug work the way it's supposed to versus not work at all or become toxic. That window can often be very narrow. And we're talking about things like radiation used for chemotherapy, where you have radiation to kill a cancer cell. Well, as you get higher doses of radiation, you get more and more normal cells killed as well, and you increase the potential for iatrogenic injuries, where healthy tissues are also killed. Here are a couple of visualizations of this concept. On the left, we have the concentration of drug in blood plasma, where repeated doses are given in order to slowly increase the concentration in plasma to where you can eventually get a more or less continuous steady state dose inside the therapeutic window. But as you can see, because the body is continuously metabolizing the drugs as well, you have to space the doses correctly. Otherwise, the blood plasma levels will dip down into the ineffective area where now you don't have enough of the drug. And of course, if you just continuously bombard a person with dose after dose, eventually you get above the therapeutic window and into the toxic window, where you get the unintended effects, the side effects, the iatrogenic effects. With radiation, again, you're talking about something that's designed to kill cells, and you apply it to tumors in order to kill tumors and help somebody to survive a cancer. Well, as you can see, the window between therapeutic doses and toxicities is very narrow. That as you get more and more tumor control by increasing the amount of radiation absorbed dose, yet you also get more and more complications because you're getting a higher percentage of healthy, non-cancerous tissue killed as well. If you err on the other side of it, where you sort of only slowly introduce the radiation and use low doses, you might not get full tumor control and the tumor comes back, which can also be a form of medical error. So on the one side, you get not proper control of tumors. On the other side, you get iatrogenic injury from extensive damage and death of healthy tissue. As I noted before, the Food and Drug Administration has an adverse event reporting system where anytime there's an adverse event that results from a drug or a therapeutic biological product, it's supposed to be entered into the system through notification by a licensed healthcare provider or a public health department or anybody else who has access to this data. So there's sometimes could be some underreporting, but the system works pretty well. And what you can see is that really in the late 2018s and early 2020s, there's been a bit of a rise in deaths and in non-serious and in serious adverse drug reactions or therapeutic interactions. And again, a lot of this, during the early stages of the COVID-19 pandemic, a lot of people were trying a lot of things that didn't necessarily work against a viral infection, but that could cause iatrogenic effects. So that might be the source of why in the years in particular 2021 and 2022 there was a bit of a spike. But yeah, in the year 2024, the last year for which we have complete data as of this recording, there were more than 2.1 million total events reported to the FDA's adverse event reporting system, more than 1.06 million serious adverse events, meaning ones that could cause permanent or long-term physical injury, and there were a little over 147,000 deaths that occurred as a result of adverse reactions to drugs or biological therapeutic treatments. Let's narrow our focus a little bit right now just to adverse reactions specifically to drugs. There are plenty of adverse reactions to other forms of therapeutic intervention, but the vast majority of adverse reactions that result in serious injury and death are adverse reactions to drugs. So we'll talk about adverse drug reactions, or ADRs, now in a little more detail. There's two primary categories of ADRs. There's type A reactions and type B reactions. The most common form are which happen about 85 to 90% of the case, are type A reactions. These are also known as augmented reactions, which are dose-dependent and predictable based on the known pharmacological properties of the drug. Again, think back to that example of the very narrow therapeutic window where it doesn't take it's not very hard to miscalibrate a dose and wind up with some adverse events that are dose dependent, meaning that if you got just a little bit more of something than you were supposed to get, you can have adverse reactions that, based on the pharmacological properties of the drug, are relatively well known. The rest of adverse drug reactions are often called type B reactions. They're known as bizarre reactions, and they're idiosyncratic and not predictable based on known pharmacological properties. There was nothing about the design of the drug that would have told you ahead of time that this is how certain people would have reacted to it. Now, with that being said, just because the pharmacological properties do not point to this particular reaction occurring, once we have at least some kind of establishment of cases, and once we have circulated that these reactions are occurring from this type of drug, then whether it was predictable based on pharmacological properties or not is kind of irrelevant. At this point, the healthcare profession has a responsibility to be mindful of the fact that type B reactions can occur as well once they become a little bit more known. Now, a lot of times, patient comorbidities and vulnerabilities are a factor in adverse drug reactions, but not always. The truth is that a lot of people in the healthcare industry try to make the case that it's always comorbidities and vulnerabilities that cause the reactions, and not the drugs themselves, and certainly not the people who are administering the drugs. And just say that that's not always the case. We can further divide type A adverse drug reactions into additional categories. The first major category being overdose. This means that you give an excessive amount of a drug due to a miscalibrated therapeutic dose, which leads to an injury or death. And again, these are dose-dependent and predictable based on the known pharmacological properties of the drug. In this case, you're getting more of the known pharmacological property than you intended in such a way that the patient gets harmed. Examples of this would be you give acetaminophen for pain relief, but you give a little bit too much and you get acute liver failure, which can be fatal and certainly debilitating. Oxycodone is a very powerful narcotic opioid that has its therapeutic use, unfortunately also has great potential for abuse, but it's got a very narrow therapeutic window between useful and so toxic to the respiratory system that it can cause full respiratory depression and collapse, often leading to coma and death. Another example would be warfarin, an anticoagulant drug that is very useful if you're trying to prevent clotting in a patient, but if you give just a little bit too much warfarin to a patient, it affects their blood viscosity. You need to have at least some viscosity in your blood because we have tight junctions, capillaries, other areas of our circulatory system that if our blood gets too thin, it can go through those openings and you can have severe internal bleeding, which often happens when people get a little bit too much warfarin administered. These are all overdose type A reactions. Another category of type A reactions is side effects. In this case, they're still predictable and dose dependent, but they're not really the principal treatment use effect. You're not getting too much of the thing you're looking for with the drug, you're just getting a known side effect that's not the principal treatment effect that can be harmful and cause injury. Example would be if you're using aminoglycosides for broad spectrum antibiotic therapy. Well, those can be toxic to the kidneys, and that's one of the side effects of aminoglycoside therapy. Just like doxycycline therapy for its antibiotic properties can also cause phototoxicity. People can be very susceptible to skin burns for periods of time after taking a lot of doxycycline. And then non-steroidal anti-inflammatory drugs. Again, they're great pain relievers, but when one of the side effects of using them heavily, but even using them at the prescribed dosage for many, many years, is the development of peptic and other types of ulcers. So again, these are side effects, another category of type A reaction. Another category of type A reaction is drug interactions, where the therapeutic agent you give will interact with other drugs, foods, beverages, supplements, or just underlying disease states and cause a negative and adverse reaction that, again, based on pharmacological properties, is knowable or should be knowable. Some examples of this would be if a person is taking warfarin for anti-clotting, but then they're also getting a lot of vitamin K in their, either through their diet or through supplementation, those interfere with each other, and the warfarin doesn't really do its job very well in the presence of excessive dietary vitamin K. We also know that for people who take benzodiazepine and also opioid drugs, that they have severe synergistic respiratory depression effects. This is a way to very quickly find yourself in a collapse, in a state of unconsciousness, and rapid death from respiratory collapse and failure by taking benzodiazepine and opioids together. Theophylline is another drug that's often taken in order to, it's a bronchial dilator, but if a person takes it with tobacco or with cimetidine, which is a treatment that's often given for gastric ulcers, or with the broad-spectrum antibiotic erythromycin, we get into a problem because all three of those, tobacco, cimetidine, and erythromycin, interfere with the clearance of theophylline, so that the theophylline, rather than being metabolized and sort of clearing out of the bloodstream, after it's done what it needs to do, it stays around. It keeps exerting effects that can lead to injuries and illnesses, and in some cases even death. So these are examples of drug interactions as a type A reaction. So now let's talk about type B reactions. A lot of times, unfortunately, we don't know what kind of susceptibility is going to be in the population due to type B reactions until drugs or treatments are released into the marketplace. A lot of times the effects cannot be replicated in animal studies or in any other studies, and so therefore we have to be very mindful of like what kinds of unusual things that are not predicted by the pharmacological properties of a drug or treatment are manifesting in the population. One big category of type B reactions is hypersensitivity reactions, where you get a rare reaction because there will be immunologic or inflammatory effects of a drug that, again, are not triggered by known pharmacological properties, but they just are, and we see in several cases that they happen. Like, for example, the chemotherapeutic drug cisplatin, for some reason that we still don't fully understand, it can often cause anaphylaxis due to cascading effects of serum IgE levels. We also know that the antibiotic penicillin can cause hemolytic anemia. Again, mechanisms not always easy to elucidate. They don't come from the traditional pharmacological properties of penicillin, but we know those effects exist. We know that people given monoclonal antibodies can sometimes develop a systemic serum sickness where they basically become allergic to the monoclonal antibodies. And we also know there's a thing called the ARTIS reaction, which is local inflammation and tissue damage from tetanus and diphtheria vaccines. And there was, again, no known pharmacological properties of the tetanus or diphtheria vaccine that would lead to this, but there's now plenty of case study evidence that these do happen in a relatively rare number of people that receive these vaccines. Another category of idiosyncratic type B reactions to drugs would be drug-induced autoimmunity. Examples of this would include isoniazid being given and then people developing a lupus-like autoimmune disease afterwards. It's not exactly lupus, but it's conditions that are very similar to lupus. And again, with no known physiological reason why one leads to the other, but in very rare cases it does. And we also see this very rarely with vancomycin, where people who take vancomycin will develop a bullous dermatosis, which is skin blistering, which is mediated by upregulation of certain IgA antibodies. And then the final category of type B reactions is just truly idiosyncratic reactions where there's no immunological reason that we can see, no inflammatory cascade reason, no reason why this drug should cause this reaction allergically. There's no known antigens on the drug that cause it, but they just happen. And a lot of times with these, the most truly idiosyncratic reactions are due to rare genetic anomalies or just highly unusual low-dose sensitivities among certain people. Some examples of this would be there are some people who, because of just some very unusual low-dose sensitivities, if they take a standard adult dose of aspirin, will develop severe tinnitus, ringing in the ears, and in some cases it becomes permanent, and they have to live with it for the rest of their life. And we still don't know exactly why it is that in a very, very rare instance, aspirin can lead to tinnitus. We also know that hemolysis can develop in people who take dapsone, which is a drug often given for Hansen's disease and other skin conditions. But for persons that have the rare genetic glucose 6-phosphate dehydrogenase deficiency, taking dapsone can lead to severe hemolysis, which can often be fatal. We will now move on to another major category of iatrogenic injuries, which is healthcare-associated infections. These are also commonly called nosocomial infections. These are any type of infection that is acquired during the process of receiving health care that were not present during the time of admission. So again, just to reiterate, a person comes into a healthcare setting without an infection, and they get the infection in the process of receiving the health care. Now, healthcare-associated infections are illnesses. I mean, they're caused by microbes. But because they so clearly fit the epidemiologic pattern of injury where a person is brought into an environment and a toxic insult occurs, and it's generally not present outside of this environment, they really do fit the epidemiologic pattern of injury, and therefore, for the most part, we can argue over the semantics, but most people in public health consider healthcare-associated infections to be injuries rather than illnesses. Why are healthcare-associated infections so common, not just in the United States, but worldwide? Well, when you get into a healthcare setting, you have a lot of patients who are susceptible. A lot of times, a lot of patients in close proximity to each other with varying types of susceptibility. You have a lot of invasive procedures taking place inside healthcare settings, particularly in hospitals. And one of the most common forms of healthcare-associated infections that we'll talk about in a little bit more detail later on is the fact that we have normal microflora on our skin and in our lumen that when they're there, in their place, they're fine. But when they get introduced into our bloodstream, they can cause severe infections that can damage tissues and cause severe injury and possibly even death. Well, when you have invasive procedures going on, such as surgeries, that greatly increases the chances that microflora of the skin and lumen and other areas can get into the bloodstream. Inside healthcare settings, you often have people that are there for long term and that have indwelling medical devices, such as catheters and bronchial tubes, which we'll talk about the reasons why these can make people susceptible to infection later on, and just the fact that there's so many pathogens a lot of times in a healthcare environment because you have so many people with so many different types of illnesses and other conditions going on. And because of a lot of people in hospitals are often on drug regimens as well, and there's not always full compliance, you actually find some types of multi-drug resistant pathogens more prevalent in healthcare settings than you do in the greater environment outside of the healthcare settings. So these are all reasons why healthcare associated infections can be very common. Healthcare-associated infections are, unfortunately, very prevalent both in the United States and worldwide. Here in the U.S., according to a 2023 estimate from the Centers for Disease Control and Prevention, every single day in the U.S., approximately 1 in 31 inpatient hospital-admitted U.S. patients will contract a healthcare-associated infection in the course of being hospitalized. For those who are in a nursing home or skilled care facility, the rate is that 1 out of every 43 persons on a given day will contract a healthcare-associated infection. Those are staggering numbers when you think about that being the case every single day. Just about any type of pathogenic organism can lead to a healthcare-associated infection, though bacteria and fungi are the most common pathogenic organisms. Bacteria are by far the most common, and the way that bacteria cause healthcare-associated infections, if you remember from microbiology or biological classes you might have taken in the past, we have skin flora, we have enteric flora, and it serves an important purpose and a job. But that enteric or skin flora can become out of place, can wind up in our bloodstream, can wind up colonizing tissues. And that's a clear case of a healthcare-associated infection. There's also what's called opportunistic infections. Again, on our skin, our lumen, and other places of our body, we've got normal microflora that do their job. But if we're on broad-spectrum antibiotics, a lot of times our normal microflora will get killed off. And then opportunistic infections, such as Clostridioides difficile, which I'll talk about in a little bit more detail later on, can take over. And they're opportunistic. When they have a little window available to them where the competing bacteria are not present, they can often take over. And as I talked about before, a lot of times in a healthcare setting, you have multi-drug resistant bacteria where the traditional therapy for killing and eliminating this particular bacteria does not work on it. Fungi are probably the other most common form of healthcare-associated infection. And again, with fungi, it's mostly opportunistic infections. You have patients who are immune compromised, and they wind up developing, for example, Candida albicans infections, which is a type of fungi. This is how we first realized that there was an epidemic going on that was suppressing people's immune systems in the late 70s and early 80s. The epidemic we now know is the HIV/AIDS epidemic. It was because fungi were opportunistically infecting tissues that under normal circumstances with a normal immune system, that would not happen. Also, unfortunately, a lot of times in a healthcare setting, people have indwelling devices such as catheters and tracheal tubes, and spores from fungi can easily reside on those indwelling devices, and then when they're inserted into the body, they can find a warm and welcoming environment for those fungi to grow quickly and lead to a healthcare-associated infection. Viruses? Well, during the COVID-19 pandemic, we found that viruses can certainly lead to healthcare-associated infections because, tragically, a lot of healthcare workers died from COVID-19 because of being in close proximity to people who were infected, who were there were aerosols being generated by these patients, and people were getting sick and dying of COVID-19. So any kind of infectious viral disease that has an airborne or droplet-borne element to it can be spread in a healthcare setting. Before we started putting in some greater protocols for use of needles and medical instruments, mostly during the HIV/AIDS epidemic, the early years of it, we've kind of stopped reusing needles and not cleaning medical instruments between uses, but unsafe needle and medical instrument practice can still lead to healthcare-associated infections through viruses, as can unscreened donor blood, organs, and tissues. Thankfully, some of the major viral infections, such as HIV, hepatitis B, and hepatitis C, are now screened are now donor blood, donor tissues, donor organs are screened for these before they're given to other people, so that these particular viral infections are not spread through these methods. Protozoa and prions, it's extremely rare for healthcare-associated infections to occur with these. Now, back before blood screening was a thing, people used to get the protozoa that caused malaria through blood transfusions, though that generally doesn't happen anymore because of, again, tight screening. And the prion that causes Creutzfeldt-Jakob disease, the human variant of mad cow disease, generally doesn't occur anymore either because blood and tissue specimens are now screened for it. So now protozoa and prion contamination leading to healthcare-associated infection generally only occurs from contaminated surgical instruments or in very rare instances where blood and tissues are not adequately screened. On the next few slides, we'll go into some greater detail about the major categories of healthcare-associated infection. These include Clostridioides difficile infections, more commonly known as C. diff infections, catheter-associated urinary tract infections, central line-associated bloodstream infections, surgical site infections, and then two types of pneumonias, ventilator-associated pneumonia and other forms of hospital-acquired pneumonias. Clostridioides difficile, or C. diff infections, are unfortunately quite common in healthcare settings. And C. diff is a bacteria that's primarily spread through the oral fecal route, But it also produces spores, and the spores can persist on environmental surfaces for months, including on things like catheters and other pieces of equipment. Clostridioides difficile, the reason why it has the name difficile is because it's difficult to fully eliminate it from settings such as healthcare facilities, because again, it produces robust spores. Now, it's not the C. diff infection itself that causes the harms to people, it's the toxins produced by C. diff bacteria. These toxins can cause severe colitis, diarrhea, dehydration, and even sepsis in very severe cases. The reason why C. diff infections are so common in hospital settings is because you have a lot of two different conditions in hospitals. You have people with compromised microbiomes because they're on broad-spectrum antibiotics, which creates a natural habitat for C. diff bacteria to grow and live because competing bacteria that would normally be part of our microbiomes is killed off by the broad-spectrum antibiotics. Also, a lot of times people that are seeking health care have conditions that compromise their immune systems so that what would normally be a small infection that the body can fight off, like a C. diff infection, becomes a much larger deal. And the C. diff infection spreads and toxins are generated and you get the severe outcomes that come from exposure to the toxins. So again, you have a lot of people in healthcare settings with compromised microbiomes or compromised immune systems, which makes C. diff infections a lot more common and a lot more serious. If you're wondering about the prevalence of C. diff infections in healthcare settings, in 2019 the CDC put out an estimate that there's about 58 healthcare-acquired C. diff infection cases per 100,000 patients. Now, that's a high and alarming number, but we should note that that's slightly lower than the community-acquired C. diff case rate, which is about 63 per 100,000. This is still very concerning, though, because we would not want to see anybody, particularly vulnerable people who are going into healthcare settings, acquiring C. diff infections. But it does show you that some of the efforts that are put into healthcare settings to disinfect and to make the conditions better so that this doesn't occur are at least somewhat paying off, because despite the vulnerabilities of people that go to the healthcare settings, the rate of healthcare acquired C. diff is a little bit lower than the rate of community acquired C. diff. But again, it's still concerning. These are hardly numbers worth celebrating. What's also known is that because C. diff is transmitted by spores, this makes it uniquely resistant to alcohol-based hand sanitizers. In many healthcare settings, in lieu of actually doing full hand washing in between patient contacts or after doing certain things, you see a lot of reliance on alcohol-based hand sanitizers, and those are great for most things. They don't really neutralize C. diff spores to an appreciable degree, though, so this is one case where we need to make sure that people that are in healthcare settings are thoroughly washing their hands with soap and hot water rather than relying on alcohol-based hand sanitizers, because C. diff is uniquely resistant to this. The next major category of healthcare-associated infections we're going to talk about is catheter-associated urinary tract infections, or CAUTI. Current estimates are that about 15 to 25% of all hospitalized persons in the U.S. end up getting a urinary catheter. An estimate from 2015 by Zabriskie was that about 560,000 people in the U.S. annually suffer from CAUTI, and about 13,000 people die of it. So, why are urinary catheters causing so many infections? Well, just think about it this way. When you put in a catheter through a urinary tract, through the urethra, the urethral tissue, yes, it's vulnerable. It can be infected itself, but at least our living organic cells can mount an immune response. Whereas when you put a non-organic, non-living plastic tube up through a urethra, that's a material that cannot mount an immune response. And so urinary catheters can spread infection a couple different ways. One, if their exterior walls are contaminated with spores, like we talked about before with C. diff, but also internally, because biofilms tend to form on the inside of urinary catheters. Because again, you're talking about a non-living usually plastic or some other type of rubberized material, so that biofilms can very easily form on this. Bacterial infections are a common result of urinary catheters, and some of the most common bacterial infections associated with this would include all E. coli species, enterococcal species, Klebsiella pneumoniae, and Pseudomonas aeruginosa. Though it's not as common, Clostridioides difficile can also spread as a result of a urinary catheter if there happens to be spores on the exterior walls of the catheter. Fungal infections are also relatively common with indwelling urinary catheters, and these can be from spores on the outside of the catheter or biofilms that form inside the catheter, with the most common fungal infection being Candida species, particularly Candida albicans. Catheterization can also increase the risk of infection from urinary due to a couple of other conditions, one of them being urinary stasis. It seems kind of counterintuitive. You assume that putting a catheter in there would help the bladder drain a little bit better. But if the catheter is not placed exactly right, it can actually cause pockets of stasis where there's certain parts of the bladder that don't properly empty because of where the catheter is placed. And this can happen even with correct placement. There can be little pockets of the urinary bladder because it's a very flexible organ that will not properly gravity empty because you've sort of replaced the bladder's normal tone and squeezing with this catheter. So you get urinary stasis, which can cause infection risk as well. And cavities are dose dependent. The risk for developing urinary tract infection increases with the amount of time that the patient is catheterized. The next category of healthcare-associated infection we'll talk about is central line-associated bloodstream infection, also known as CLABSI. There are many procedures that require the heart to be catheterized, and one of the most common ways to catheterize a heart is to go through the superior vena cava, this large vein that carries deoxygenated blood into the right atrium of the heart. Now, there's a few different pathways that can lead to the superior vena cava, but most of the time, that is the target of catheterization into the heart. And so what happens when you try to catheterize this pathway into the heart, you can have infections in a very similar manner as you do with CAUTI. The catheter itself could have some external contamination on it, particularly with some hard-to-kill spores. The catheter can produce biofilm, particularly the longer it's put in. What's a little bit more likely with CLABSI compared to CAUTI is that because it tends to go in through the skin of the chest, the shoulder, other places like this, it's a little bit easier for skin microflora to enter the catheter during insertion or positioning when you're talking about catheterizing the heart versus catheterizing the bladder. So, yes, skin microflora can make it into a urinary catheterization as well, but it's a little bit more common with heart catheterization. The next category of healthcare-associated infection is surgical site infections. Current estimates in the United States are that surgical site infections occur in about 2 to 5% of all patients undergoing surgical procedures. Usually the source of a surgical site infection is the patient's own microflora, because again, during a surgical procedure, the microflora we have on our skin or in the lumens of our GI tract or genital tract can get into the bloodstream and wreak havoc. Again, because the surgical procedures expose these normal flora to the bloodstream. The most common source of surgical site infections from the patient's own microflora tend to be bacterial. Things like E. coli and Staph aureus species, Klebsiella, Enterobacter, Enterococcus, and Streptococcal species. Less common sites of surgical site infection, but ones that we still need to be vigilant about at all times, are ones caused by the surgical environment, like surgical instruments, healthcare personnel, or the surgical environment itself. Surgical instrument as a source of site infections are less common now because of widespread use of autoclaving in between patients or things like ethylene oxide sterilization. Usually surgical instruments are very thoroughly disinfected in between uses in such a way that that's not likely to be a source of infection. Healthcare personnel, of course, if the healthcare personnel have any infectious illnesses, or if they've got some unique microflora on their skin. This is why it's so important for all healthcare personnel to scrub thoroughly with disinfectants before they enter the surgical theater, and then put on their full gown and full personal protective equipment. Yes, this protects the healthcare personnel from any exposure to any infections that the patient has, but they also protect the patient from any infections or any, even just the normal microflora of the healthcare personnel themselves. And of course, the surgical environment itself can also be contaminated with a lot of times there's a lot of blood and other potentially infectious materials that flow in the surgical environment during a surgical procedure that has to be cleaned very well in between patients. And again, we have to be just meticulous because some things, such as C. diff, are hard to kill, particularly the spores of C. diff. So, while these are not the most common sources of surgical site infections, continuous vigilance is still needed to ensure that SSIs do not occur in these environments. The last category of healthcare-associated infections I will discuss in this module are ventilator-associated pneumonia and other forms of hospital-acquired pneumonias. Many people who get admitted into a hospital wind up being put on a ventilator and being given mechanical ventilation. Of people who receive this mechanical ventilation, anywhere from 5 to 15% of them will develop ventilator-associated pneumonia. Usually, VAP is bacterial in origin, with Staph aureus, Pseudomonas aeruginosa, and other gram-negative bacteria being the most common source. The story of why it is that people who get ventilated wind up with ventilator-associated pneumonia should be a little familiar to you now after we just talked about urinary and heart catheterization. And it's kind of a similar idea where you're putting an artificial airway, in this case usually plastic or neoprene or some other material, and putting it down through the trachea and into the upper reaches of the lung. And what you're doing is you're completely replacing the normal immune response that our living tissues in those areas have with this thing that has no immune response at all because it's an object. And of course, these artificial airways can be readily colonized on the inside through the formation of biofilms, just like catheters can. But then also, this artificial airway defeats a couple of important mechanisms that our body has. We have some natural defense mechanisms in our upper airways to help us get rid of bacterial and other invaders. One of them is the secretions of mucus. The mucus that we secrete in our airways can engulf bacteria and other things. It can be sticky and it can kind of engulf them and neutralize them. And then we have little cilia that can sort of move these balls of mucus with embedded bacteria and other invaders upwards in our upper respiratory tract, so where they can be coughed out or spat out. Of course, if you put in an artificial airway, you completely defeat these mechanisms. So this is why it makes the lung a little bit more susceptible to pneumonial infection. In terms of other types of hospital-acquired pneumonia, there's a lot of different pathways by which a person's lungs can become infected in a healthcare setting that don't involve a ventilator. This can be due to aspiration of things, direct aerosol inhalation, bacterial translocation. This can happen with many other healthcare things, or just a lot of times you wind up with material in the bloodstream entering the lungs and then causing an adverse reaction that is a form of pneumonia. So I know that was a lot of talk about all the problems associated with iatrogenic injuries in healthcare settings. So now let's talk about some of the solutions, some ways that we can prevent these, and we'll start by talking about prevention of medical errors. One of the most important ways to prevent medical errors is communication. And that sounds simple, but it'll show you it's actually a lot more complicated than that. And there's multiple layers to this. Some of the most important communication that can prevent medical errors is clear and unambiguous interprofessional communication. In other words, communication between healthcare workers, between people that are on a healthcare team for a particular patient. One of the most important things, and it's so simple, but when it's integrated, it prevents so many medical errors, is a simple read back between a practitioner and any downstream healthcare workers, whether that's a pharmacist that a physician is calling a prescription to, or somebody farther down the chain of the, pro the provider chain, making sure that instructions for what to do next, that it is recited by one person, and then the person that's receiving the instruction repeats this back to the other person, and and once both sides agree that yes, the communication has been effectively given, the instructions have been both received and heard correctly, only then do they go their separate ways. I mean, that is one of the most important things that can be done. Read back between healthcare workers at all levels. And also the ability for healthcare workers to bring up concerns without fear of reprisal. A lot of healthcare teams tend to be quite hierarchical, where the attending physician, who is sort of at the top of that hierarchy, doesn't always welcome feedback about any concerns that other people in the team have. And that's just antithetical to preventing errors. All teams should be encouraged to bring up concerns without fear, and also to report errors, not just errors that actually result in injuries, but near miss errors, or errors that almost happened, or conditions that, if left unaddressed, could cause a medical error that could hurt somebody down the line. This is something that, again, if you have medical teams where this sort of thing is encouraged, there will be fewer errors. When we're talking about surgeries in particular, because a lot of medical errors happen in surgical theaters, having periodic checks with all healthcare workers before, during, and after surgeries. What actually helps is to do an official surgical checklist during a surgical procedure, where there will actually be somebody reciting all the steps and what's supposed to happen at every step. This is particularly important in certain stages, such as maybe when the surgical procedure is completed and you're getting ready to sew up a patient, making sure that every single piece of surgical instrumentation is accounted for so that one of them doesn't get sewn up inside the patient. Well, actually having somebody reciting, that now we are going to count all the instruments and make sure that we have the same number that we started with before the surgery, that can prevent a lot of medical errors. And just making sure that there's clear communication anytime there's orders given downstream from the initial provider to pharmacists to interns, to anybody who's going to take over some element of the patient's care after the initial interaction is completed, making sure that there is absolutely no doubt as to what is supposed to happen next, that orders are clearly written, that specimen containers are clearly labeled, prescriptions are clearly written so that the pharmacist does not have to try to figure out what the doctor meant when they wrote out this illegible handwritten note. This is where electronic systems sometimes help, because that's you don't have to decipher somebody's own handwriting if they're using an electronic system. But regardless, just making sure that anytime a patient is handed off from one element of the healthcare system to another, that all communications are absolutely clear and unambiguous. And then when we talk about communication between the healthcare provider and the patient, it's also making sure that that's clear as well, that there's clear communication of what's going to happen, clear agreement of what's going to happen. One of the biggest examples of this that really helps a lot is surgical site labeling. There's a lot of body parts that a human has where we'll have two or more of them. And it's important to label which one is going to be the subject of the procedure. If you have two eyes and you only have a cataract in one of them, it's important to label which eye is going to get the cataract surgery, or which knee is going to get the arthroscopic surgery, or which body part is going to get amputated. There have been a number of medical errors that have occurred when a surgery has been done on the wrong body part because it wasn't clearly labeled and there wasn't clear agreement between the provider and the patient beforehand of like, okay, we're going to do an arthroscopy on your left knee today. We're going to operate on your right foot today. So again, that's that surgical site labeling that you saw in the stock photo on the last slide. That's very important to reduce medical errors. and really just encouraging an environment where not only patients, but families and loved ones of patients can have all their questions answered about how care is going to be delivered. In other words, not having a rushed environment where communication tends to be short and to the point, and where a lot of times questions go unanswered because people are being sort of feeling rushed. And as we'll get into in the next few slides, there's some structural issues that would also reduce medical errors if we address those. As this is a public health course, I would be remiss if I didn't also mention that one of the best ways to prevent medical errors would be to address some major structural issues in the U.S. healthcare system and the way that healthcare is delivered here in the United States. If we could restructure the healthcare system in a very thorough way and improve the medical work environment, we would reduce medical errors. One of the biggest ways we could reduce medical errors is by addressing duty hours and workloads. There is ample evidence, both within the healthcare settings and almost any other workplace setting that you could ever look into, that error rates increase as fatigue increases. So the longer that a person is on a shift, especially without a break or a time to rest or anything like that, the greater the error rate is going to be. And we're talking about a healthcare setting. Nobody wants to make medical errors, but the human ability to focus just does degrade over time as fatigue increases and as stress increases on long shifts. We really should reconsider how we staff the healthcare system, because if we don't have adequate staffing right now so that people are working 12 and even 24-hour shifts, we're producing the kind of fatigued environments where errors are going to be more common. We just are. We got to be honest about that. Also, because of the current healthcare system emphasizes speed and throughput and trying to minimize the amount of time that is taken per patient in order to see more patients. I mean, that's when you emphasize speed and throughput, you're going to have more errors. This is also consistently seen in the medical industry, it's certainly seen in the meatpacking industry. It's been seen in the automobile industry. You see this over and over. When you de-emphasize speed and throughput and create an environment where all questions can be answered, where people actually check once and check twice before they do the next thing, and where people are not just chronically fatigued, this would reduce medical errors by quite a bit. It's also important to make sure there's extra oversight and support for particular tasks that can be very error-prone and where medical errors and also, as we'll talk about later, adverse drug reactions can occur, which is the administration of medication. This is not a time to have a situation where somebody is incredibly fatigued, where maybe you have a pharmacist who has been at their duty station for hours on end without a break because there's been a steady stream of either patients or healthcare providers coming by to have prescriptions filled and have things done, and they haven't been able to rest or have a snack or take a restroom break. That increases error rates. Another thing that happens sometimes in healthcare settings is that a lot of times the principal physician will not be available, or the nurse practitioner who's in charge of something will not be available, and so increasingly healthcare delivery tasks might fall on providers who maybe don't have adequate knowledge or experience. They're just the people who are available at the moment to do this, and that's, if you want to prevent medical errors, you want to take the time to ensure that everybody who might have to perform a task in the healthcare delivery system knows what they're doing, is well trained in it, is prepared to do it. For adverse drug and treatment reactions, again, one of the most important preventive strategies is communication. Making sure, and we talked about this on the previous slide with medical errors, making sure there's adequate time for a thorough patient history to be given, so that patients are able to give detailed and open information about their full medical history, their vulnerabilities, what current medications are on, any known allergies and previous adverse reactions. A lot of times in the current settings, patients are encouraged to get through this as quickly as possible. Maybe don't take the questionnaire very seriously. Maybe don't take the questions from the healthcare worker very seriously because there's a there's sort of like a pressure on everybody to get this done as quickly as possible. But if this information is not conveyed adequately, adverse drug and treatment reactions become a lot more likely. And then from the provider side, making sure that regular adverse event education occurs is critically important. It's important to have case reviews periodically of like interesting case studies of what's happened with this new medication, and particularly for type B adverse reactions, where this is something that nobody guessed was going to happen when patients were administered this drug, but we've seen it in a few cases, and so now we need to be aware that even though we don't understand the pharmacological mechanism, if you're going to give this particular drug or treatment to this patient, you might want to, for example, screen them for glucose 6-phosphate dehydrogenase deficiency first. And you might need to screen the patient for other markers and other behaviors, other medications that would make this a particularly not good drug or treatment for them, likely to cause an adverse reaction. And then, of course, when adverse treatment or drug reactions do occur, there needs to be a deep root cause analysis. Don't just write it off on like, okay, that was an idiosyncratic reaction from a patient, or one person should have paid more attention, or whatever. It's like, no, do a deep root cause analysis of, from the very beginning of the system, what could have been done differently to prevent this from occurring. But again, those also take time, which is something that is not always available in modern U.S. healthcare systems. Both sides should be completely clear, both the healthcare provider and the patient, on directions for how to take medications. What is the dose you're taking? What is the timing? How many hours are supposed to pass between doses? Are there other specific requirements? Are you supposed to take this medication with food? Are you supposed to take it without food? Are you not supposed to take it before rigorous exercise? I mean, these things need to be both communicated and understood before a drug is given. This is not, handing a patient a safety data sheet or a patient data sheet is not sufficient. These need to be orally communicated and a response received back that this is understood. There should be communication from patients who are taking one medication about what they're on before they start taking a different one. And of course, providers should ask this question and not try to hurry the answer, but actually, take the time to look up, okay, you even for like vitamins and supplements, there are some supplements that people take that might cause an adverse reaction of a prescription drug that they're now going to be given. It's really important to communicate to patients that they need to be paying attention for the first sign of any change to their health or to their body response after they start a new medication or a new treatment, because early adverse reaction identification is so critical. A lot of times, certainly with drugs, but really with all forms of treatment, there can be early signs that this is not going to work very well for a patient, that there's going to be an adverse reaction likely. And a lot of times these are ignored because it's not communicated to the patient that, hey, you let us know if you have the first sign of anything changing after taking this medication. This would really help a lot to keep, because if a person keeps taking a drug for which they're going to have an adverse reaction, the likelihood of a severe injury is it increases exponentially. And again, just like with medical errors, for adverse drug reactions and adverse treatment reactions, there are structural issues in the healthcare system that make these a little bit more likely and that need to be addressed if we're serious about preventing these. Proper health communication takes time, and providers having a limited amount of time with a patient to explain key information can be a factor in adverse treatment outcomes. Well, providers having more time to explain key information and making sure that it's clearly conveyed can be a factor in reducing adverse treatment outcomes. And then as members of the public who are going to interact with the healthcare system, there is a role for education on our part as well. I mean, we should understand before we start taking a drug or a therapy, what are the normal and expected side effects of it? Even if our provider doesn't tell us, there's other reputable sources of information where we can learn this. I mean, if we're taking a drug or a chemotherapy or a radiotherapy, what are the normal and expected side effects versus what are the abnormal and unexpected side effects that mean that we need to go to the emergency department as quickly as possible? That's a lot of times first signs of serious adverse reactions are missed because people don't know that that's not normal. That's not supposed to happen when you take this drug or undergo this treatment. And so, yes, it's important for the healthcare system to educate us before we receive the treatment. We also have to educate ourselves as well before we go in for things like this. And it's important for the public to be educated if they're going to receive these types of drugs or treatments, that how can the known predictable adverse events be moderated or accommodated outside of the healthcare setting? Like when you're at home and you're taking a drug that induces nausea, how do you manage that? What is the way to make that become such a maybe not so adverse or not so disruptive to your everyday life? And it's really important to encourage everybody receiving healthcare, particularly more invasive and more advanced healthcare, to self-report any mental health side effects of these drugs and treatments, because this is a really underrated part of some of the bad things that happen with our interactions with our healthcare system, is that nobody tells a chemotherapeutic patient, for example, that there's some things that you're not going to have the energy to do, or just the mental burden of seeing your abilities, either temporarily or permanently taken away by, by radiation therapy or by an amputation or by surgery to fuse discs in your back that keeps you from being able to do some of the things you were doing before that. I mean, these are all psychological injuries that happen as a result of interactions with the healthcare system, which, yeah, the other things that would happen if these interactions did not occur might have been worse. Suffering from cancer is probably worse than the side effects of chemotherapy if the chemotherapy cures the cancer. But just the fact that these mental health effects are disregarded largely and that people are not adequately educated on them just does not do any of us any good. And so encouraging the observation and the self-report and the taking seriously of mental health effects from treatments and drugs, I think, is very important, and we should advocate for that as public health-minded people. For healthcare-associated infection prevention, let's start by talking about Clostridioides difficile, or C. diff, infection prevention. Surveillance and immediate testing in healthcare settings for everyone is one of the most important things that can be done. And this includes healthcare workers. Patients and healthcare workers need to be tested anytime they exhibit a sentinel symptom, which for C. diff infection, diarrhea is one of the sentinel symptoms. And if you're a healthcare worker who has a diarrheal illness, yes, having to report that when you go to work and be tested for C. diff is probably not an enjoyable thing, but this is one of the ways that we can prevent C. diff from becoming such a chronic problem in healthcare settings. And then for positive cases of patients, making sure that they are isolated and that there's contact precautions for them, thoroughly cleaning all surfaces with adequate bactericidal, virucidal, and sporicidal disinfectants, making sure that all healthcare workers frequently hand wash with soap and hot water, rather than over relying on alcohol-based hand sanitizers, because, once again, to remind you, C. diff is primarily spread through spores, and spores are largely resistant to alcohol-based hand sanitizers, but they are vulnerable to soap and water. And it's important to note C. diff vulnerability for patients who are on broad-spectrum antibiotics. If you have a patient who's taking vancomycin or some other broad-spectrum antibiotic, more than likely a lot of their normal microflora has been killed off, and so that means if they catch C. diff, it's likely to have a lot of ability to just take off and run rampant in that patient. Similarly, if you have a patient who's immune compromised, which happens a lot, a small C. diff infection will not be contained in them the way that it would in a person with a normal immune system. So these are just some of the ways that we can prevent C. diff infections in the healthcare setting. To prevent catheter-associated urinary tract infection and central line-associated bloodstream infection, one of the most important things to do is catheter management. Make sure that patients who are catheterized and through the bladder or through the heart have a daily assessment of their condition, the condition of the catheter, including whether it's showing signs of cloudy opacity or biofilms growing inside it, and just whether there's a need for continued catheterization. Is the patient's condition stabilizing or improving to such a degree that maybe the catheter can come out? Because the longer a catheter is in place, the greater the potential for both CAUTI and CLABSI, depending on the location of the catheter. You can use antimicrobials in the inside the lumen of the catheter, but you got to be careful with that, because like with antibiotics you give to a patient, if you use antimicrobials but you overuse them, or you're not prudent with their use, you can actually get microbes that become resistant to the antimicrobials. And then if you have resistant microbes developing inside the catheter biofilms, that greatly increases infection risk. Certainly, adhering to strict standard operating procedures for the sterilization of catheter equipment, and for the handling of equipment after it's been sterilized, and for the insertion of equipment by healthcare workers. Again, insertion is where a lot of problems occur, because you'll get tissue damage at the point of insertion, and then that creates a place where infectious microbes can get into the bloodstream. Certainly, once again, strict hand hygiene for healthcare workers is important, and discouraging healthcare workers from coming in to work when they're ill, discouraging what we call presenteeism, where people who have a transmissible illness still feel like they need to come into work. Having leave policies where people can miss work and to recover when they have one of these illnesses, rather than coming in and possibly spreading it, is very important for preventing these types of infections. Surgical site infection prevention starts with the careful use of preoperative antibiotics, and of course, not the overuse of preoperative antibiotics. Also, it's always good to attempt to decolonize specific pathogens on the areas such as skin surrounding the incision site or an IV insertion site, because those are the ones that can, if they get into the bloodstream, as will often happen during a surgical or IV insertion procedure, can wreak a lot of havoc. If a surgical site has a lot of hair on it, it's important to clip the hair rather than shaving. This reduces the risk of tiny little epithelial microtraumas, which can cause deeper-seated bacterial penetration. It's important to maintain hygiene control in the surgical theater, even in the postoperative phase. There's a human tendency, once a patient is sewn up, to sort of relax, and you start taking off the gloves and not being quite as meticulous, but you don't want to relax controls just because a patient is sewn up. They're still very susceptible to a surgical site infection at these times as well. Postoperative care is important. Reduce the potential for a surgical site infection by frequently changing dressings, because dressings that are caked with, the materials that are often ooze out of a surgical site can prevent infections, along with monitoring incision sites and drainage of sites as necessary. That's not a particularly pleasant experience, but it can reduce the risk of infection-related complications. And once again, we have to talk about structural issues. When you have a surgical environment that is not predicated on speed of completion, but that is where sort of meticulous checking and rechecking occurs at every stage along the way, that reduces the likelihood of a surgical site infection. For preventing ventilator-associated pneumonia or other types of healthcare-associated pneumonia, once again, it goes to structural issues. Being able to communicate well, have enough time for proper communication, for ensuring that everything is checked and rechecked, and that employees are not fatigued, that patients can get all their questions answered, and just again, you want to also monitor for signs and symptoms in patients who have underlying risk factors such as pre-existing lung disease, patients that have poor oral care so that it's likely that they have dental caries and some other regions in their mouth that can possibly seed an infection into the lungs, particularly once you intubate them so that their mucociliary clearance mechanisms are not working anymore. Certainly any patients that have any immunosuppressive condition as well, they need to be more closely monitored for ventilator and other types of hospital-associated pneumonia. And then careful use of antibiotics. In some cases, antibiotics are great because they will actually kill the pathogens associated with these pneumonias, but also with the realization that many VAP and HAP are caused by multi-drug resistant bacteria that might not respond to the antibiotic that you're giving. And that antibiotic is instead killing away some of the normal and healthy flora that can help repel some of these invaders and not create an environment for them. And when we're talking about ventilator-associated pneumonia and just ventilators and intubation in general, just continuously reassessing the need for a patient to remain ventilated, because the longer a patient is ventilated, the greater their risk of developing ventilator-associated pneumonia. Okay, we're nearing the end of this module, and now we're going to have to talk about something that's not going to be comfortable to talk about, but we just need to acknowledge this. Mental health and public health programs, policies, and interventions often carry iatrogenic effects. There will be unintended physical, mental, and social harms that sometimes result from even the best planned of these interventions and programs and policies. And sometimes when these are not particularly well designed, there's even greater potential for unintended physical, mental, and social harms. So let's talk about this. An important part of the public health mindset is caring about individual well-being, but also the well-being of populations and systems and ecosystems. But that means that if we're going to do any kind of intervention, put any kind of program in place, we need to do an honest and ethical evaluation of all of the outcomes of our interventions, programs, and policies, the intended ones and the unintended ones. And we just have to always keep in mind that if we're trying to do something that impacts people, well, people are complicated. What people want is sometimes complicated. The day-to-day struggles of people can be complicated, and especially the environment in which people live, work, play, and receive information is complicated. So this means that often when we intervene in the lives of people, there will be unintended and possibly negative outcomes. People that go into the mental health and public health professions generally care about people and they care about seeing positive outcomes. But at a population level, even the most well-intentioned policy choices and interventions can have profoundly negative unintended consequences that we need to make sure that we are measuring. And at the first sign that these unintended consequences are creating injustices or outcomes we really don't want, we need to pause and acknowledge this and maybe change course. We should never adopt a fully utilitarian mindset in public health of, well, my intervention helped 100 people and hurt 10 people, therefore it was beneficial to a society. We should never adopt the mindset that if a minority of any sort, a minority population is harmed, but the greater good is helped, that means that we've done something good. That's not just, that's not ethical, and so we simply cannot allow our public health to be that way. And here's some examples of, again, some mental health and public health policies that were done that had some unintended consequences. So this won't just be a esoteric concept here, but there'll be some actual concrete examples. There was a program throughout the 80s and 90s given in U.S. schools called DARE, or Drug Abuse Resistance Education, which was supposed to keep kids off drugs, to increase their awareness of drugs, but then decrease their usage of it. But it was found that in a lot of cases, this was only not ineffective, but it actually increased usage of drugs by children who received the drug abuse resistance education. So completely opposite of what was intended, because for whatever reason, the materials, this was the outcome in a lot of populations. In the module about non-suicidal self-injury, we talked about iatrogenic effects being a concern with any school-based programs for these. Because if you acknowledge the reasons why people do self-injury, such as cutting, and you acknowledge that one of the main reasons that people give is emotional regulation, the truth is self-harm is an effective form of emotional regulation. And that's why I was a little bit reluctant to even include that information in the module. But as public health minded people, I think we all can agree that that's sort of not a very good method of emotional regulation. There's other methods of emotional regulation that are less harmful and that we should be promoting instead. But yeah, that's another example where there have been NSSI awareness programs that have increased the risk of non-suicidal self-injury amongst participants who receive the program. We know that in order to get children to become more active and to fight childhood obesity, there's been an increased emphasis in many neighborhoods for increasing participation in organized sports such as soccer, football, and many other sports like that. Not just informal sports, but organized team sports. What's happened in a lot of neighborhoods where organized sports are promoted is that, yes, children might become more active, but they also suffer more injuries, more orthopedic injuries, more concussions. And so this is a iatrogenic effect that we need to be measuring and watching out for if we're promoting certain types of organized sports that increase the risk of head injury and orthopedic injury. We know that trying to improve neighborhoods and make them more livable and improve the built environment is a noble goal, but the way that it's been done in a lot of neighborhoods, particularly here in the U.S., by increasing transit-oriented development, and building more park space, building bike paths, and again, improving mass transit so that places become more desirable and less car dependent. What that does is it also increases property values, which can be a good thing, but it can also lead to gentrification, and it can lead to housing insecurity for longtime residents who suddenly can't afford to pay the rent in this neighborhood anymore if they're renters, or maybe if they're property owners, their home value's gone up, which again, on paper sounds good, except that means that their property tax bill also goes up. So a lot of times, improving neighborhood built environments actually changes the demographic composition of a neighborhood and squeezes out longtime residents and also longtime business owners who can't afford the business rents anymore. And so this harms people. And that's something we need to be aware of when we're promoting certain types of built environment interventions. And this last one, this is very controversial, but I just got to say it. Here in the Nevada system of higher education, back in 2021 and 2022, there was actually a COVID-19 vaccine requirement in order to be continuously employed by NSHE or to continue to be enrolled in NSHE institutions. And if you opted not to receive the COVID-19 vaccine for religious or other reasons, and you signed the waiver, there was kind of an onerous requirement for weekly testing to prove that you were COVID-19 negative. And did this do more harm than good? That's one of the questions that I'm going to ask you in the discussion board post. I mean, the COVID-19 vaccine was effective and is effective on many of the antigen types of COVID-19 and preventing illness from becoming severe, and reducing the severity of it. But in terms of preventing spread of COVID-19 from person to person, many of the vaccines, as it turns out, were not as effective as we maybe hoped they would have been at that. And here in the United States, especially, where employment is tied to health insurance, which therefore is tied to a person's ability to receive health care, I think some legitimate questions can be raised about whether mandating the COVID-19 vaccine for continued employment, if the harms that resulted from that were maybe too great compared to the good that might have come from that. We will now talk about another area where public health might have done some unintentional iatrogenic effects. In the early 2000s, there was a big focus across many areas of public health on obesity prevention. It was seen as the major public health and health crisis in the United States for several years. And there were a lot of public health interventions that were done in these decades, through the 2000s and the beginning of the 2010s, that focused a lot on promoting weight loss and actually doing interventions where you put people on diets. Well, the sad truth is, and this has been seen over and over again in many studies, diets generally do not work for more than about 6 months. They don't really work in the long term. A lot of times people invariably gain all the weight back unless you deal with some underlying issues as well. I assigned you this article from Bristow and colleagues that talks about some of the one of the key unintended consequences of some anti-obesity public health campaigns from this era. And this is something to keep in mind. Anytime you do a public health intervention, there will be an intended audience, but there will also be a spillover into unintended audiences. One of the unintended audiences for a lot of these public health campaigns was people who are at risk for eating disorders. And the article goes into extensive detail about how people at risk for eating disorders can be mentally and physically injured by obesity prevention campaigns. There's a not insignificant portion of the population that's genetically at risk for anorexia. And so when you have an information environment where people like that are continuously receiving messages about losing weight, and then in a lot of cases with people with this genetic risk for anorexia, once they actually severely restrict their calories and go into energy deficit, this is actually a form of emotional regulation, and that kind of feels good and becomes sort of self-feeding. So this is an example of people who are directly harmed by a well-intentioned public health intervention. But it goes even beyond that. Even the intended audience, the people whose body mass index might put them at risk, might be a risk factor for heart disease, hypertension, and diabetes. I mean, even the intended audience can feel stigma from these campaigns, which resulted in many counter-healthy actions and outcomes. And the truth is, a lot of the public health focus on promoting weight loss and restriction of foods and things like that neglected a lot of the biological, societal, and environmental influences on a person's weight. The biological influences are just that some people are not going to be able to be at a low BMI regardless of how restricted their caloric intake is. Societal influences, well, I mean, certainly the weight stigma itself is a societal influence, and the discrimination against people who are above a certain weight or certain body mass index. But also, we live in a very stressful society at times where people often have high cortisol levels, which affects metabolism. And also, part of our stressful society is that a lot of people are continuously having to do things, and they don't really have time to cook, you know, good, healthy meals. And that's where, processed and fast foods often play a role. And then, of course, when we talk about environmental influences, as public health minded people, you should know that our food environment here in the United States is not particularly good for reasons that should already be familiar to you. What I hope we all realize now is that instead of promoting public health for this obesity crisis that involves stigmatizing and shaming people and focusing on making the number on the scale smaller, the focus should be instead on small and positive behavioral changes. Trying to do interventions to increase fruit and vegetable intake, to increase levels of physical activity, decrease consumption of certain ultra-processed foods and sugar-sweetened beverages, and increase sleep, and doing some other techniques to maybe give us a daily harbor from all the chronic stress and cortisol production. Those are the things we should be focusing on. And just keep this in mind, obesity is not a behavior. Those other things I've talked about, those are behaviors for which public health can try to work and try to promote those improved healthy behaviors in society. Obesity is not a behavior. Here are some strategies for prevention, or if prevention is not completely possible, at least mitigation of some of the iatrogenic effects that might happen from mental health and public health interventions, programs, and policies. One of the biggest ones would be regular ethics training. Certainly for people that are in the mental health realm, people like licensed psychologists and therapists, regular ethics training is required to maintain professional certification. But even if you work in these realms and you don't have professional certification, it's good to periodically meet with colleagues to talk about some of the ethical issues and ethical quandaries that come up, to actually read journal articles that discuss these sort of things. Don't be don't be so tunnel vision focused on what you're doing that you not only don't pay attention to the iatrogenic effects of your own actions, but that you're unaware of the iatrogenic effects and some of your colleagues might have encountered. Just regular ethics training and just real talk about it is an important thing. Certainly, if you work at the university or really any kind of funded research environment, if you're going to do research on human subjects, it has to go through an institutional review board. Before institutional review boards existed, there was a lot of very harmful human subjects research that where it wasn't just the unintended consequences of research that were bad, but even the intended consequences of some of the research was there were not governing bodies to say, no, you cannot, of course you cannot do that harmful thing on human subjects. But IRBs now are getting trained better to look at possible unintended outcomes as well that could be negative. I think one of the most important things you can do if you want to unfurl a policy, a program, or intervention within a community is make sure the community is involved early on. Community-based participatory research. This can prevent a lot of iatrogenic effects. A community will know what some of the unintended consequences might be of this well-meaning thing that you want to do for them. They will know. They can help you to design for and prevent some of those effects going in, asking some of the correct questions. This is going into a community without their involvement and their input is how a lot of iatrogenic effects occur. Now, community-based participatory research is not a complete inoculation against these effects, but it can greatly reduce the likelihood of them. And you get more community buy-in into the intervention program and policy as well. So that's why community involvement, I know it takes more time, but it's really worth it. And finally, if you want to be an ethical public health researcher, you need to measure all outcomes, not just the ones of greatest research interest. And when you measure all outcomes, you need to report all outcomes. You cannot selectively omit from publication the outcomes that make your intervention look bad. This is a form of publication bias by which a lot of useful information that could have kept other public health and mental health professionals from making the same mistakes, this information doesn't get conveyed, and so the same mistakes get made again. You simply must not do this. You must include in any kind of publication or any kind of promotion of something the outcomes that maybe don't make your intervention look so good. If you succeeded in making a neighborhood lose weight, but you promoted unhealthy eating behaviors and triggered eating disorders in that neighborhood, you simply must report that information as well. And of course, you should seriously consider whether your intervention should continue on if you see these iatrogenic effects piling up. So as I wrap up this lecture, let me just emphasize this important point one more time. Most people in the caring professions in medicine, dental health, mental health, pharmacy, public health, they do not seek to cause physical, mental, or social injuries through their work. However, iatrogenic effects can and do occur, and vigilance, mindfulness, ethical discipline, and honest communication will always be necessary to prevent these types of injuries, or at least to mitigate their severity and minimize their likelihood of occurring. Iatrogenic injuries are uniquely harmful because they harm people, certainly, and that can result in tragedies when people get severely injured or killed as a result of interactions with the caring professions. But there's a ripple effect that goes well beyond that. When people are harmed, the reputation of these professions is also harmed, and as the carefully built credibility and trust that people have in the caring professions is harmed, and people are not seeking out the services of these caring professions, again, that can have wide public health implications. So that's why iatrogenic injury prevention and mitigation is so important, and why I decided to devote a whole lecture to it. So that's it for this week. Let me know if you have any questions or comments. Thank you for your attention today.